Professor Sundararaman is currently a member of the Global Steering Council of the People's Health Movement, and he has worked several civil society organizations, and from 2003 he headed the state and national level health systems resource centers supporting health system strengthening in India. He was also professor and dean of the School of Health System Studies in TIS in Mumbai, and currently an adjunct faculty at the School of Public Health in JIPMER. Perhaps you could spell out the full name for that. Thank you very much. He's going to talk about the unrestricted analysis of the COVID narrative in Africa. Lockdowns as a crisis of both public health and science policy, learnings from a case study. Is that right? Okay. Thank you very much, and please take the floor.
Thank you. To introduce myself, I retired from active service, but I continue to retire. I have retired 2-3 times now. And I'm part academic. A lot of my thing has been as professors in different schools of medicine. JIPMER, incidentally, is the JIPMER, Jawaharlal Institute of Postgraduate Medical Education and Research. That's in South, in the Puducherry. And that's one thing. And I've also been a lifelong activist for health rights. And very many people know me as that because I've been working for health rights within the country and outside. And at times when the government was favorable or willing to listen, I've also been working with helping governments make policy on this. So I have a unique vantage point, and in COVID-19 all came into play. But sometimes it is not such a blessing because all of them disown you equally also. So you're always the other. So each person is saying, oh, you're not part of us. So I'm choosing to take one example, but the issues I touch upon are actually general. And I know they are general because I have been developing case studies from across many countries, and we have a collection of case studies as part of the Global Steering Council work of the health systems thing. The case study I take off is Tamil Nadu, which is, I'm a Tamilian, I come from Tamil Nadu area. And Tamil Nadu has a population of about 80 million. It's the southernmost state of India along with Kerala. It's the 6th largest by population. About half of its population is in urban areas, and in terms of GDP, it is the 2nd highest province in the country. So essentially what I'm saying is not the story of a very backward, underdeveloped area, but an area of reasonable development with a lot of strengths in the health system. It's particularly known for much better than the average performance on the indicators. Now, the COVID-19 lockdown occurred in Tamil Nadu like it occurred in many other places. It was a very strict lockdown, and it started even a few days in anticipation of the national lockdown. And there was a complete shutdown of all educational institutions, all recreational institutions, all cultural institutions, all religious festivals, all workplaces, and of all public transport within 2 to 3 days notice. At best, and most people didn't even understand that this was going to happen when it was announced. Within 2 days, everything was shut. Suddenly the streets were deserted and there was police everywhere, and the whole effort of this was actually a policing effort on this. This was done under the authority of the National Disaster Management Act, which gives a lot of powers to the central government, overriding the provinces, and they can deal directly with district officers and the security apparatus. Now, there are 3 features of this lockdown that are highlights, but they are highlights across the world. We have presented webinars internationally on the militarization of the COVID-19 pandemic, and we can see the same features everywhere. But the 3 features, and I'm going to spend more time on discussing the implications for policy and science. So I'm just giving you a background description. I think I would be sharing this with most of your histories also. The first was the brutal, uncaring enforcement of restrictions by the state security apparatus, characterized by a very high and unnecessary use of force, violation of civil rights, stigmatization, even criminalization of those with disease, and the extensive violation of human rights in this process. one must actually understand the brutality in real terms. You had at one time newspapers reporting on the progress of government control efforts in Tamil Nadu. And they would be reporting the total number of arrests have reached so much. The total number of vehicles impounded has reached so much. So on a particular day, on April 2nd, a newspaper reports 38,387 persons have been arrested as of date and 28,040 vehicles has been seized. This is shown as a mark of achievement, of a mark of how well they are enforcing the lockdown. This is a projected figure, a figure used for monitoring lockdown, because the entire understanding of this was that at some point people are not really going to obey these restrictions. The rich may can, but the poor cannot, and therefore they have to be forced. This logic is an interesting thing, but it is absolutely there. In its worst cases, there were torture-related deaths of people who broke the lockdown. The famous one in Tamil Nadu was Thuthukudi, which of course drew a storm of protest, but there was no avenues for protest and it was cut down, where a father and son who kept their mobile repair shop open after into the night curfew hours were taken to the police station and punished to be set an example, and it went out of control. Related to it was, of course, also different types of criminalization and terrorist profiling of lockdown offenders. So one of the major events at the beginning, the country claimed that lockdown had been perfect and the whole disease had been contained, but there were this group of Muslims who had come, evangelical Muslims who had come for a meeting in Delhi, but they had hid out, and the disease had spread amongst them. They had come from many places, and now they were going all over the place in spreading the disease. And it's actually at some point a Muslim ploy. Given the Hindu majority government that we had in particular place, this Tablighi Jamaat, it's a certain sect of the Muslims, and they are evangelical, but they are, as Muslims go, very non-fundamental, very eclectic, very much more secular, much more on their own thing, a really innocent crowd. But they were highly stigmatized, and you would have statements from as senior persons as secretaries saying there's no spread in Tamil Nadu except for these guys who have gone around and spread it, and we are after them, we'll catch all of them. And there were demands for this. So this brutalization of the thing, there are many examples. To save time, I'm not going into it, but this is a story of a complete violation of rights in many ways. And it occurs as some sort of a necessity of the program. The second, of course, is the complete disruption of social and economic life and the push into poverty and hunger of millions. This is again very understated. This, of course, many people will be talking about, so I'm not going to spend time on it, but that does not mean it is not there. Just to give you a certain incidence, one of those handling civil society run help centers reported that for the first time they heard a lot of people in good English, obviously well-educated people ringing up and saying, "Ma'am, can you tell me where we can get some food?" So these were shop girls working in malls, in up country areas, in more elite areas. And when the malls had closed down, they were without food, and they had come in and lived that. And they didn't know, unlike even the poor, where some level of community support would kick in, they didn't know even where to go to get a hunger bailout. So the extent of hunger in these periods can be vastly underestimated, continue to be underestimated, though there are number of papers now that have actually looked at this. So a complete disruption of social and economic life. No other past episode has done that. And the third disruption is the disruption of all healthcare services. I have a paper in this in the Asia Pacific Journal of WHO where we explored this across all the South Asian countries. I know in India in some detail, but you can refer to that. I'll give you that reference on this. And the pathways to such, the interesting point for me was the pathways to such disruption. These disruptions were not any spontaneous disruption or inconsequential unintended collateral damage due to the lockdown. They were part of strategy. So health systems preparedness, for example, meant that all the public hospitals were converted, the government hospitals were converted into centers awaiting COVID admissions. For a lot of the time, they were not even filled. But therefore, the patients, inpatients, which are largely from the poor who seek care in public hospitals, were turned out. You had pictures of cancer patients sleeping under the flyover in Bombay at night because of this. But you had, Tamil Nadu wasn't so bad, but eventually what you did have was more than 50% of the population, the beds where they sought care had been slashed off. So in some sense, it was intended. Private sector and a whole part of state policy had been to shift government role to purchasing some private sector rather than public provisioning. This has been the whole trend of universal health coverage, what passes in the name of universal health coverage. Last 5 minutes, I've just finished my first 5 minutes introduction. Okay, so in some sense, this would actually be led to a disruption. The point was, each of these disruptions were policy steps on it. Now, without much further ado into this, the second part of this, there is also as a result a very high degree of stigma and what we would say mass denial. And this mass denial can be interpreted in different ways. Sometimes it can be used to interpret, I saw in some of the papers that actually the pandemic didn't occur, which was a big problem for us because there were deaths occurring over there. Even when there were bodies floating down the Ganges, there could be denial of the presence of a pandemic in their midst. So there were some issues on that. Now, the issue about the lockdown, the public health rationale of the lockdowns, three rationale were used. One rationale was we are preventing something called community transmission. Community transmission was the big evil, and a very strong state will prevent it. It's somewhat similar to zero COVID that China talks of. It was we would prevent community transmission, and community transmission is actually a containment measure meant to prevent everything. Therefore, it is not only the probable modes of transmission, but even possible modes of transmission that have to be curtailed in a major way. Therefore, the strictness of the lockdown, where very absurd possibilities of transmission should also be locked down, flow from the fact that any possible source of transmission is to be treated with the same weightage. So if you are driving a scooter without a mask on the road or driving a private car without a mask, you could still be arrested because there is that particular chance that you may cough into the environment and a passerby may pick up that thing. In public health sense, it's nonsense. But at some point, this is the justification using that particular area of uncertainty to do that. The second thing was preparedness. Oh, we are needing a lockdown to prepare for actually very little preparation happened except in testing where good work was happened. And the vaccine, by the time it came, actually infection of the majority of the population had taken place. So the notion of lockdowns as justified by preparedness, the requirements of preparing a system for it are very not possible to defend. A third possible rationale for the lockdown was the issue of what was called flattening the curve, but in an intermittent way, not mitigation in the overall sense, but a certain sense of when the hospitals are getting flooded, at that time to impose intermittent lockdowns to reduce the pressure on the hospitals. Now, this had a particular logic, but there were no clear rules on how this can be done, and there are still no clear rules on that. But further, there were a number of features of lockdowns or restraints. Now, I'm getting very thing by it, like night curfews. Across the world, across our thing, night curfews. What particular value does public health do night curfews have? Brief 1 or 2 hour curfew relaxations, where therefore the entire crowd will assemble in the ration shop just otherwise wouldn't have been crowded. Now you are imposing crowds on different area. Closure of public toilets, recommended by an expert committee in area where there were no toilets, domestic toilets. Closure of public transport. Completely bizarre restrictions on the disposal of the dead. Lack of permission to go for a walk in the neighborhood. And even at the individual level, actually, the cartoonists had a field day. So people will be wearing a mask, but when you're feeling like a sneeze, you take it off and have a proper sneeze and put it on again. I mean, because at some point, the mask gets completely wet on that. So at some point, there's a huge amount of areas with thinking. The problem of this which you relate is to the way how science and public policy deals with uncertainty. Risk is calculated, estimated uncertainty. But where estimates of uncertainty are slow to come in, you are actually the nature of the authoritarian nature of the state's takeover. So this whole bizarre, we have a prime minister who's famous as declaring that what governance needs is a 56-inch chest. I mean, not a whole lot of meaning, a very macho, strongman appeal, which does bold moves. 3 minutes. Okay. So, and therefore, you have actually that authoritarian nature of the state that begins to dominate on that. We can understand the nature of the state in some way. More difficult to understand is what happened to the advice of the scientific community on this. Again, the relationship between uncertainty. First thing is the authority structures within the advisory of science policy and public policy. How many people who are expert clinicians and or market leaders in the private sector or public officials, clinicians holding public office became advisors with no understanding of public health whatsoever. And then you have actually the fact that when they don't really know, they too go along with a certain stream of what is particularly popular, and it's opinion that passes off for evidence. And as there is a famous aphorism of a minister saying that, if it is opinion, let it be mine. It's my opinion. If it is evidence, please bring it on the table. But in a scenario where there is no absence and expert opinion passes for absence, both the problems of uncertainty and ambiguity. You have two experts saying two opposite things. How do you reconcile this issue? What actually happens in the reconciliation is important. So let me conclude. I have a whole lot to say, but I will circulate this paper, which I used to write it up. It's much longer than this. But one of the interesting things, this aerosol, I saw that in your book. We came on to this in a very different way. We came on to it in public communications. I refuse personally to allow a great discussion on the aerosol and droplet, because when translated into the vernacular, it made very little difference. And it was confused with airborne transmission. So you have to 2 kilometers around infected case, you have to have a isolation containment because it can spread through the air as an aerosol. So the whole nature of risk communication had a big, public messaging and communication had a big problem on it. But finally, what I would like to end with is, at least with medical care, you sort of know what we learned out of the COVID-19 pandemic. In intellectual patent rights and what is called vaccine apartheid and what is called the vaccine, we actually know some of the messages, we have generalized it. In the ongoing discussion on the pandemic treaty and the international health regulations, there's a lot of good work coming in from civil society, academics, third world countries on issues related to technology. On lockdowns, there is complete silence. The silence is overwhelming. And the problem which I really think is, even the question is not perceived. In some sense, at the end of the day, did lockdowns work? We don't know. Did these restrictions in lockdown work? We don't know. Is there ongoing research that can crack this? There isn't. Is there actually a public discourse shaping about it? At some point, like a disaster, if you have an earthquake or a tsunami, you take that as a given factor and you really look at how state responds to the tsunami. The lockdown is now equated with the pandemic. In a sense, therefore, that you say pandemic, lockdown. And therefore, it's not about whether you need lockdowns, how you need lockdowns. It's not seen as an artificial, a man-made, a humanity, a social decision. It is equated with a natural decision on that. That, I think, is one of the big problems that we need to tackle. Thank you.
Very much so much. Yeah, thank you.